Hey everybody, this is Dr. Godo. Welcome back to our Better Clinician series. Today we'll be talking about SIADH. This kind of goes back to our previous lecture on hyponatremia. The reason I brought SIADH out in a separate lecture is one, the other lecture was getting way too long and I don't have the attention span for it. And two, I see SIADH all the time in the hospital. It's very common, but a lot of people don't really understand the pathophysiology or kind of what we're doing, and I just want to clarify a lot of different things. We see it all the time, so let's just clarify some things about it. SIADH, what is it? It's syndrome of inappropriate antidiuretic hormone. It's in the name. So you have way too much ADH. For whatever reason, you have way too much ADH. And again, it's a cause of hyponatremia, but it's not a primary problem. Usually this is caused by something else. If you can figure out the causes, you can figure out the treatment, and you can hopefully prevent it from happening again in the future. So let's kind of build up our differential about what causes this. Then we'll look at our diagnoses, and then we'll look at our treatment options. So there's a few causes, but we'll kind of talk about our main 5 of them. And these are things that are fairly common. The first one's going to be thyroid. Thyroid diseases can cause SIADH. Brain diseases, such as seizures, strokes, anoxic brain injuries, can cause SIADH. Infections can cause SIADH, sepsis. You have all this dysregulation of all these hormone imbalances. So infections is another cause of SIADH. Cancers, neuroendocrine, tumors, metastatic cancers can cause SIADH. And the last thing that we see here is going to be our psych meds. Psych meds, I'm going to put a little star next to you because personally, this is what I have seen as the most common cause of SIADH between psych and infections. That's kind of what we see more often. Psych meds in particular that you have to look out for, or just meds in particular that you have to look out for, are going to be your SSRIs and your antipsychotics. Even opioids like morphine can cause SIADH. And there's other medications that, besides psych meds, that can cause it, but these are going to be our main causes of SIADH. So how do we really diagnose this? You have to have a high index of suspicion. So to diagnose this, we'll put it here, you have to have a couple of things. The first thing you have to have is you have to have the proper clinical picture. We discussed this in the previous video, but you're going to have to be presented with the euvolemic, hypotonic, hyponatremia. That's going to be the first thing. That's going to tell you, hey, I have to follow that rat's P mnemonic, and from there we can go on to suspect SIADH. But before we go on to the second thing that will help us with the diagnosis, I want to talk about what ADH really does. ADH is released, and it comes here to the back part of this nephron. I hope you guys all recognize that as a nephron, and it goes here to the back side. I don't want to get too technological with the terminology here, but ADH comes here, and what it does, it basically reabsorbs H2O, reabsorbs water from your nephron. So you have a net positive H2O, and what this causes is a excretion. It causes all the water to get outside of the nephron. So in the nephron, in the urine, it's going to be very concentrated. So your urine osms are going to be elevated. And the other thing that's going to be elevated if you're reabsorbing all the H2O is going to be your urine sodium. Is going to be elevated as well. So when we diagnose SIADH, you want to get these two lab studies, or urine osms and your urine sodium. So our second diagnostic criteria is going to be your urine osms are going to be elevated, and usually this is going to be around like 400, 500, 600, 700, very, very concentrated urine here. And our urine sodium is also going to be elevated, and this is going to be elevated more than 20, 30, so it's going to be like 40 plus. And it's very concentrated urine. So this is really how we diagnose SIADH. How do we treat it then? We treat it via the same kind of concept. The big question that we ask here is, do we do we give or hold fluid? Because a lot of times you'll see it in the emergency room or on the floors. Let's give this guy a liter of normal saline and see what happens. But if you think about the pathophysiology with the nephron, what ADH really does, it will help us with our kind of decision-making process. So let's right here again. What does ADH do? ADH goes here to the back of the nephron and causes H2O to be reabsorbed. Okay. So now let's say we suspect it's SIADH, but we give this guy a liter of normal saline. Right. So what does a liter of normal saline have? A liter of normal saline has 154 milliequivalents of sodium chloride, but that is carried by 1 liter of H2O. Okay, a lot of people forget about this 1 liter of H2O that this sodium chloride is dissolved in. This will get filtered by your glomeruli, pass through this nephron, and the H2O is going to be reabsorbed by your ADH, which causes your urine to excrete a bunch of sodium. So urine sodium will increase even more, which causes your urine osms to increase even more. So this causes a net H2O reabsorption and a net sodium excretion. So the answer to this question is no. Do not give fluids. You want to hold fluids. And this is kind of why we do that. And really, if you understand why we do this, you'll understand SIADH. So that's SIADH in a nutshell. Again, this is a very brief and quick overview, going over kind of the different causes of it, the diagnosis, and our treatment. If you have any questions, concerns, or comments, please leave them in the comment section below. If you have any recommendations for future videos, please leave your recommendations below. Please like and subscribe to the videos. It really helps with the YouTube algorithm. Hope you all are becoming better clinicians out there. Thank you so much and have a good day.